Thank you. So this is a scientific abstract. This is work that has been performed in our centre, sponsored by the Peter MacCallum Cancer Centre, received funding from Theragnostics in collaboration with our colleagues from King's College London, Philip Blower and Greg Mullen, who have invented the THP chelator that's used in this study. So cold kit radiopharmaceutical kits have really been the majority of nuclear medicine carried out in the last 25 years using single-step radiopharmaceutical kits where we elute the gallium generator, add it to a GMP freeze-dried kit. This is simple, reproducibly, low handling, sterile, pyrogen-free, and the regulatory authorities are happy with this. And now we have potential to do the same with gallium-68 now that we have approved gallium generators. So this research uses THP, tris-hydroxypyridone, a bifunctional chelator which has high labelling efficiency at a variety of pHs and at room temperature, with the prospect of eluting the generator, adding it to the vial kit, doing very simple QC as you would for conventional nuclear medicine, and then injecting it into the patient. Some of the preclinical work for this substance was done in our centre by Peter Roselt, our radiochemist, Rod Hicks, in his preclinical lab in collaboration with Phil Blower that invented the compound, and Michelle Ma, who's from Melbourne but now back at King's College London, with THP octreotate and also using an RGD peptide as well. The THP chelator works really very well across a variety of different scenarios, and the final product can be produced in 1 to 5 minutes. So the primary objective of this study was to assess the safety of gallium THP PSMA, to look at the biodistribution of the agent and calculate radiation dosimetry, and the secondary objective was to assess the optimal imaging time point and to look at immunohistochemistry expression of PSMA and compare it to the PET scan. We've completed to date Group 8 of this prospective trial, which was a group of 8 patients. These were patients with biopsy-proven adenocarcinoma of the prostate that was scheduled to undergo prostatectomy, and the exclusion criteria was any prior treatment for prostate cancer. After the THP PSMA was injected, we did dynamic PET imaging. This was a vertex to mid-thigh with very quick 30-second bed steps repeated 7 times so that we could get a whole body overview of how the biodistribution changed, and then further imaging at 120 and 180 minutes. We also did some venous plasma sampling at regular time points to look at clearance. And there's a second group of 6 patients that we're currently scanning, which has a different inclusion criteria where we're comparing it to HBED PSMA 11, but this component of the study has not been completed to date. So we've scanned 8 patients. You can see their Gleason scores here and the PSA's clinical stage. 7 or 8 of these patients had MRI as part of routine clinical care. All patients were imaged successfully, and there were no adverse events. Patients were monitored throughout the study and also followed up at 24 hours. We can see from this scan that we had 2 negative scans where no prostate cancer lit up on the scan, and the other studies had uptake above background, so a positive scan. And there was 1 patient where we saw lymph nodal metastases. You can see the SUVs of the uptake in the prostate gland here. So the average SUV was 3.8 or 5.1 if we exclude the 2 negative patients, and the maximum SUV was 9. All these patients proceeded to surgery for radical prostatectomy, and several of these patients also had extended lymph node dissections as per routine clinical care. You can see there were 2 patients with N1 disease with negative PSMA PETs, but those tumours were 0.6 millimetre or 0.1 millimetre histopathologically. So this is not disease that we would expect to see really with any PET imaging agent, so I think we can't really call them false negatives. They're just microscopic disease below PET resolution, but we didn't see any patients with macroscopic disease that were missed. And then we had 1 patient that was PSMA PET positive, but the nodal in a lymph node, but the nodal dissection was negative. And this was actually likely a histopathologic false negative, since the PSA did not drop to undetectable after the prostatectomy. This is the first patient that was scanned. You can see our imaging algorithm where we're doing imaging at multiple time points. We get a lot of scans. This is the late time point image fused to the MRI scan. We can see good uptake within the prostate gland. These are the 8 patients that were scanned, normalised to an SUV scale. And some moving MIP images. A few patients had relatively faint uptake. This is one patient. I'm just changing the windowing. We can see that when we have a very narrow window, we do see some uptake, but it is low grade, probably in keeping with small volume disease. This is a case with more impressive focal intense uptake, co-registered with the MRI scan. We have learnt some things doing this protocol. These patients had a low dose CT at the 15 minutes, and then that was repeated at 120 minutes and 180 minutes. So the repeat imaging at the time points between 15 and 90 minutes did not undergo repeat CT, but the bladder was filling over that time point, and that led to misregistration between the PET and CT images, particularly at the 60, 75 and 90 minute time points. This is an example of a patient with quite high uptake in the prostate gland, an unequivocal uptake within a 3 millimetre internal iliac node, and also in a further lymph node slightly superiorly. This patient had Gleason 9 disease. The patient proceeded to surgery, but the histopathology from the nodal dissection was negative. But as I've alluded to, on follow-up, this patient has a rising PSA, so this was likely a histopathologic false negative. All these patients, the prostatectomy specimens were stained with PSMA immunohistochemistry so that we're able to compare the uptake on the PET scan compared to the histopathology. This was done in 4 quadrants, and here you can see that the 2 patients without uptake on PET had the lowest staining of PSMA PET, so 1+ or 2+, 5 and 40%, whereas all the other patients had 3+ and high staining. So the 2 patients with no PSMA PET uptake had low uptake on immunohistochemistry. This is one such patient. This was a little bit alarming. The patient had a Gleason 10 cancer with a PIRADS 5 lesion on the MRI scan. The PSMA PET showed absolutely no uptake, and we may have expected to see some uptake, but the histopathology showed very little PSMA staining, so this was a PSMA negative cancer. That patient actually underwent an HBED PSMA 11, which was done on sort of routine clinical grounds after the THP PSMA scan, because they were concerned that this could have been a false negative scan, and the HBED PSMA also showed no uptake in that prostate cancer. But it allowed us to compare the biodistribution of the 2 scans, and we can see that there is differences in salivary uptake and liver spleen uptake between the 2 agents, so they're not, the biodistribution is not identical. We've done dosimetry using patient-specific 3-dimensional image-based dosimetry using Olinda EXM software. And you can see the effective dose of in millisieverts per megabecquerels, which amounts to about 2.8 millisieverts for a PET component of the scan if we gave 150 megabecquerels. This is quite equivalent to the PSMA 11. So in conclusion, a kit-based production is feasible. The compound is safe. The biodistribution is as expected for a PSMA ligand. We did see focal uptake in the prostate gland corresponding to the site of malignancy on histopathology. The PET findings correlate with immunohistochemistry, and the radiation exposure to the patients is relatively low. Thank you very much.
Thank you. Thank you very much. We have a little bit time for questions. There's one question from Frank Rush.
What is the binding affinity of the compound?
The binding affinity of the compound? That's a good question. I don't know that I have the data to answer that question. But there is some preclinical work that came before that, so I might have to defer that to the radiochemists, if there's any radiochemist that's involved that wants to answer that question.
Michael, may I ask you a question? That's a very elegant study, but it does open a can of worms. What will you say to the patient who would rather not have a radical prostatectomy because he doesn't want to become impotent, incontinent, or have the other toxicity of surgery? If you've shown excellent uptake in the prostate, perhaps with one lymph node metastasis, and he says, why can't I have lutetium up front instead of having other toxic chemotherapy? What your reply now would probably be, well, that's not a reasonable request, but more and more people are going to make that request of you. What are you going to think of in the future?
So I think you're alluding to bringing lutetium PSMA very, very early into the treatment algorithm as an upfront treatment in patients with intact prostate glands, perhaps even without nodal involvement. And I think it's probably fair to say that there's well-established standard of care therapies for prostate cancer, i.e. surgery or radiation, particularly with the high-risk prostate cancers, and then that would be considered a non-standard of care treatment. And if we're going to embark on such an approach, it ought to be done in the context of a prospective clinical trial, and I hazard to guess that that is a difficult prospective clinical trial to perform because the ethics committees may say that there's insufficient evidence to bring the therapy so early on. What sort of supporting data do you have to use it so early on? So I think we take the other approach and start using lutetium PSMA at the end of the spectrum and hopefully bring it backwards in a sequential fashion.
Given the lack of evidence, would it surprise you that the request is most likely to come from one of your colleagues? Are there any other questions? Thank you very much, Michael. That's a great talk.